Okay, let's resume again. The second part for the start of clinical neurological examination. Okay, we will go through the following. We go to the inside the station, doing greeting for the examiner firstly, and go to the patient to greet the patient. Before greeting the patient, you need to do hand sterilization very well. While you're doing hand sterilization, read the label above the patient to know what is the request needed from you to do exactly. Okay, so do hand sterilization, then greet the patient, introduce yourself. I am Dr. X, I'm Dr. Magraby. I would like to examine you. Is it okay with you to take or to gain a verbal consent? And to maintain the patient welfare, ask about, do you have any pain or discomfort? Please, if you have any pain or discomfort, let me know. So to avoid touching or to avoid manipulating of this specific area of pain by a rough method, try to be gentle in examination, take permission before each step, share the patient with you in the steps of examination. Okay. After that, you will do what's called a general survey by inspection all over the patient. You know that examination of the surrounding of the patient is a part of examination of the patient. Okay, we will go to the side of the bed at the leg of the patient and tell the patient that I would like to have a general look from the foot side of you. Okay, you are checking the patient if any abnormality can be appeared to you, if the patient is comfortable or no, if the patient has any clue at the surrounding, like if the patient has any cannula, the patient has any walking aid, patient has any wheelchair beside him, even the shoes of the patient. Sometimes you can find that there is different in the size of the shoes, especially in case of polio. If you notice that and mention that to the examiner, you will impress the examiner. Search for any scars, obviously to you, scar in the leg, scar in the neck, like this, any scar, wasting of the muscles. You can do the test of fasciculation when you are examining the upper limbs or lower limbs to make gentle flickering of the muscle to see if there's any fasciculation or no. Check if the patient has tremors. In case of Parkinson, usually the patient try to hide these tremors, but if you concentrate or ask the patient to put his hands in an obvious way in front of you, you can see easy the tremors of Parkinson, resting fine tremors. You can do what's called a screening test. Some persons don't like that, just to make a screening which limb is affected. If you would like to know if this patient has monoparesis or paraparesis or hemiparesis, like this, you can simply ask the patient to raise both upper limbs and raise the legs. So if the patient raise upper limb good, but lower limb is a problem, so you are dealing with paraparesis or spastic paraparesis or flaccid paraparesis. If one limb only is difficult to move, so it is a monoparesis. If the patient has one side only is weak and the other side is normal, so mostly you are dealing with a case of stroke. Okay. Let's go to the examination of the lower limbs. Okay, in lower limbs examination, we have the main 5 cornerstones items, which is tone, power, reflexes, coordination, and sensation. This is the 5 items in examination on lower limbs, even in upper limbs. Okay, you are examining the tone, power, reflexes, coordination, sensation. Specifically in lower limb, do not forget the gait. The gait is very important to be examined, especially in the examination of the lower limb. Also, if you have a patient, you ask it to examine the upper limbs and you find Parkinson's, definitely you need to examine the gait to see the specific pattern of choking gait of the Parkinson. So the gait examination is very important. Do not forget to do it or even to mention it. Okay. When you start to examine the gait, there is a transition zone. You will ask the patient to stand up, then he will go, okay, or she will go. When the patient stand up, you can do a checking of a deep sensory affection, which is called a sensory ataxia. This is dorsal column affection. It's called Romberg sign. Romberg sign that you ask the patient to stand and to close his eyes while you are protecting him to avoid his fall. If the patient is, you will feel the patient is about to fall while he or she close the eyes, this is called sensory ataxia, okay? And this is a positive sign called Bomberg sign, okay? So when you do the gait, you can do this for a few minutes if you would like to examine the dorsal column and to rule out or rule in the sensory ataxia. Also very important to check the back. Any lower limb examination or even some upper limbs examination, if you find some clues related to back affection, you need to check the back. You will find a scar in the back, okay? And the back, I mean from all the dorsal column, all the spinal dorsal column from the back till the cervical spines. So check the back all over. Okay? You might have a scar in the back in case of spastic paraparesis, and this patient has history of all the trauma. Okay, all this patient has metastasis or operation in this back, and this is the cause of spastic paraparesis, for example. So examination of the back is very important. Also, in cases of cervical myelopathy, you will find a scar in the cervical spine of the back of the patient. You need to expose the scalp and the cervical spine to see this scar. Otherwise, you will not reach a diagnosis of cervical myelopathy, and this is an operation. Okay. So we can put it as 7 items: tone, power, reflexes, coordination, sensation, plus gait and the back. So put in your mind these 7 items while you are examining. Okay, let's start one by one. Regarding the tone, how I would like examine the tone. I know it will be some difficulty to imagine, but I'd like to put the highlights about each item. You can apply this on the clinical cases later. Okay, for tone, you are doing rolling of the leg of the patient to check any spasticity or any flaccidity of the leg. Okay, also you can do leg lifting to elevate the leg from the couch at the part of the knee, at the area of the knee, just to elevate and make it fall by its default, but protect the leg from hitting the wall or hitting the couch. So you are checking the tone of the leg by this, by rolling of the leg and lifting of the leg. And while you are making like this, you can also do the tone through the joints. I mean, you can make a flexion of the leg. You are catching the leg by your hands and make flexion at the hip and knee like this, and also the other leg flexion and extension through the knee and the hip. And at this time, you can check also the tone if there is any hypertonia or if there is any spasticity. Okay, and also you can do what's called clonus. Clonus is you are catching the foot of the patient and do a repetitive movement like this, and then after that stop. You can see the patient own foot is moving like a repetitive movement, like scissoring like this. So this is called a clonus. Okay, this clonus is a pathognomonic or a feature of upper motor neuron region. Okay, so you can pick by this that you are dealing with an upper motor neuron region. Okay. After tone, you are going to checking the power. Power, it means the strength of the muscle. So you are checking this strength along each joints. You are checking along the hip, the knee, the ankle, and big toe. For the hip, you have 4 movements. Ask the patient to approximate the leg to inside. Okay, this is called adduction. Adduction meaning add. Add, you are collecting and you are giving, you are bringing the things to each other. So adduction, the patient approximates the legs together, or abduction, the patient push the leg outside laterally in the same direction, and flexion and extension of the hip, the patient doing flexion of the hip and extension of the hip. Flexion means that he approximates the thigh to his abdomen. Extension means he is pushing the thigh out like he is pushing the couch. Okay. In knee joint, simply there is 2 movements: the flexion and extension. And ankle, you have also flexion and extension, which is called plantar flexion and dorsiflexion. And the ankle joint can be everted and inverted. Inverted to the inside side and everted to the outside. And lastly, the big toe, you are checking the extensor hallucis longus. Okay, this is related to the bulge. tone, power. Then after that, we go to the reflex. In reflexes, you are checking the important reflexes in the leg, which is the knee reflex, ankle reflex, plantar reflex. Okay, it's important to know the spinal segment affection of these reflexes. Okay, knee reflex L3, L4, ankle reflex is L5, S1, and plantar reflex by S1. Okay, the plantar reflex is usually done by not by the hammer. Okay, knee and ankle you are doing this by hammer gently, and in knee you are making tapping at the patellar ligament, not the patella itself, to not harm the patient. And in ankle, you are making a specific extension of the tendo Achilles tendon, so that you can tap the tendo Achilles, and you check the contraction in the calf muscle. Also in the knee, you are tapping the knee reflex, and you are checking the quadriceps muscle. It's very important here to expose the muscle while you are doing the any reflex. Expose the quadriceps muscle while you are doing the knee reflex, and expose the calf muscle while you are doing the ankle reflex. And in plantar reflex, it is not recommended to do it by the hammer, not recommended to do it by a pen, not recommended to do it by a key, not recommended to do it by any sharp object. There is a specific not a needle, it is a plastic part inside the exam. It can be used for this. Okay. After doing these reflexes, you have what's called pathological reflexes. If you find that this patient has hyperreflexia in the knee, in the ankle, or the plantar reflex is extensive, there is an positive plantar reflex. I mean, there is a fanning of the toes and dorsiflexion of the big toe. This is the definition of positive Babinski sign. Positive Babinski sign, it means that this patient has a hyperreflexia and there is dorsiflexion of the big toe and fanning of the other toes. By this positive Babinski sign or hyperreflexia in the knee or ankle, so this is a manifestation of upper motor neuron lesion. You can confirm that if the available other pathological reflexes or not. Okay, so adductor reflex and the patellar reflex, you can do it only in case you find there is hyperreflexia. If you did not find hyperreflexia, so no need to do adductor reflex and patellar reflex. Okay, the adductor reflex in the adductor muscle, you putting your fingers in the adductor tendons and tap on the finger like this. You'll find the leg would be go to inside, and the patellar reflex that you are pushing the patella down to downside by your finger and tap above your finger. You will find also there is a positive reflex. This is a feature of pathological reflex. So now we can collect the pathological reflexes are adductor reflex, patellar reflex, and clonus. So these three are considered as pathological reflexes. Okay. I'd like to highlight for you, while you are doing reflexes for the patient, try to do it from one time. Do not hit the region many times. By hitting many times, you will lose the sensation and you will lose the quality of the test. Okay, so do it one hit time. If you find that you cannot elicit it well, ask the patient to do reinforcement. Reinforcement means that you ask the patient to clench the teeth. Ask him, please clench your teeth, and while he's clenching the teeth, tap the knee reflex, okay, or tap do the ankle reflex. Okay, this is reinforcement. Clench the teeth, or even he can clench his hands to each other, just to redirect the patient to not concentrate with what you are doing, so you can elicit the reflexes as normally. Try to protect yourself while you are doing the reflexes to give the patient space and maintain the patient welfare. Do not let the patient to say, oh, do not tap on a bone. Do not let any limb of the patient fall down or touch the wall or touch the couch forcefully like this. Okay. Then we'll go to the coordination. So I'll finish tone, power, reflexes, coordination. What about coordination? Coordination is a test for examining the cerebellum. To examine the cerebellum. Cerebellum examination you can examine the cerebellum in upper limbs, in lower limbs, and in eye in the form of nystagmus. Okay, so it is not necessary to find the coordination test is impaired in upper limb only, lower limb only, in eye. If you would like to examine the cerebellum, you need to search for in upper limbs and lower limbs and in eyes. Okay. We will mention that later. In lower limbs, you ask the patient to do a heel chin test. Heel chin test means that you ask the patient to move one knee, to move the ankle of one limb all over the knee of the other limb alongside the shaft of the tibia. Okay, and then to do the opposite by the one side of his ankle, go through the other side of his knee joint and go through the tibia like this. Okay, this is called a heel chin of the tibia test, heel chin test. Okay, you need to do this one by open eye, then by closed eye. Okay, the other test is tapping. Tapping means that ask the patient to tap the sole of the foot on your hands, on your palm of the hands, to check if tap good or no. And if you cannot elicit this in the lower limb, it may induce that this patient has cerebellar lesion, or the patient has a weakness, so he cannot do this coordination. Maybe he has weakness, so he cannot do the heel chin test, he cannot do tapping well, okay? Or maybe he has a joint proprioception abnormality, so he cannot put the ankle of one limb over the shin of the tibia of the other limb. So at this time, you can, if you suspect cerebellar lesion in this patient, like you are facing a patient with multiple sclerosis, for example, MS, okay? So you would like to check if this patient has cerebellar affection or no. You can ask them, I'd like to check the cerebellar affection in other parts, not in the lower limb, like check in the upper limbs, ask the patient to do dysdiadochokinesia, to do finger-to-finger test, finger-to-nose test, to check if there's any post-pointing like this, okay? Or you can check the eyes of the patient to see if there is nystagmus or not, okay? This is the coordination. So tone, power, reflexes, coordination. Then the fifth item is the sensation, okay? In sensations, you have 4 types of sensation, okay? As we mentioned before, you have the 2 tracts, dorsal column tract and spinothalamic tract, okay? And you are using 4 methods: light touch, pinprick, vibration, proprioception, okay? As we mentioned before, the vibration and the proprioception is carried by the dorsal column, okay? While the light touch and pinprick is carried by the spinothalamic tract, okay? This information is important also if you would like to save time and you did the pinprick, like you did pinprick sensation, okay, for example. And you are in hurry in your time, and you find that there is no enough time for you, okay? After you doing pinprick examination, okay, and you know there is, for example, a sensory affection to specific level, say some trunk affection till the level of umbilicus, for example, okay? The light touch will not add more to you, okay? So you need to do both, okay? You need to do both, but to know that the light touch usually will follow the pinprick because both are carried by the same tract, which is the spinothalamic tract, okay? For vibration and proprioception, okay, it is the same. It is carried by the dorsal column tract, but in vibration, you are checking the level of impairment of the vibration affection. You are going through the bony prominence. Start from the big toe at the bone of the base of the big toe, then go to the medial malleolus and put the tuning fork, then go to the chin of the tibia, then go to the tibial tuberosity of the knee, then go to the anterior superior iliac spine, Then after that, you can go to the bony prominence, which start from the lower costal margin, go rib by rib till reaching to the clavicle up to the mastoid bone. Okay. In vibration sense, we are using tuning fork, especially the one of the frequency of 128 hertz. Okay, 128 hertz. There is another one will be 256. This is not for vibration. This is used in hearing test, like you are doing the hearing examination in Rene and the Weber test. Okay, so if you find two tuning forks, the one for vibration sense is the frequency of 128 hertz. Okay, for the pinprick, you are using what's called neurotip. Neurotip is a plastic part, and if you remove the upper plastic part, you'll find a needle. By this needle, you are doing the pinprick. Try to do this pinprick gently, not to do it perpendicular of the skin, just make it like tangential. Just you are checking if any pinprick, pain sensation or no. Avoid to go by depth of this needle inside the skin. This is very painful. Avoid to let the patient to bleed from your touch. All this will be a negative mark for you. Okay, so be gentle and keep the patient welfare. For light touch, you are using the cotton just to check the cotton light touch of the patient. So we are doing a step-by-step light touch followed by pinprick, and after that start by the vibration from down up as we mentioned, and the proprioception is the joint position. You are catch the joint of the patient, especially the big toe, and firstly let the patient to know this direction is above for your big toe, this direction is the down of your big toe. Then ask the patient to close his eyes. Then after that, ask him. You will move the toe of the patient and ask the patient. Now, where is your big toe? Is it up or down? He will mention to you, up or down, like this. If he can be aware to recognize the position of the joint, so he has intact proprioception. Otherwise, this is an impairment of proprioception, which is a sign of dorsal column affection. Okay. Here, I would like to I forget to mention in the firstly, when we started to examine the sensation of the lower limbs, for example, firstly, give a patient a reference point. Reference point, it means that I would like to check now the pinprick or light cotton. I would like to give a patient reference point. So firstly, put this cotton at the sternum of the patient, okay? Or put this pinprick at the sternum of the patient. Or also the vibration tuning fork, make it when you hit the tuning fork or touch by your fingers to make it vibrate, and put the base of the vibration tuning fork over the sternum of the patient and tell the patient, can you feel the vibration now? Not the coldness of the tuning fork, the vibration. Okay. Okay. And also ask him, do you feel the prick here? Okay. Also by the cotton, do you feel here the touching of the cotton in your sternum area? Yes. After that, you're giving the patient a reference to know what he will feel in the lower leg. Okay. Then you will go by each one. By the cotton, you ask the patient at the sternum, you feel here the cotton? Okay. Go to down and check the patient while asking the patient to close the eyes. Okay. Tell him, do you feel the cotton now? Like above, like what you felt already at the sternum? Okay. Is it yes or no? Is it you are feeling the same or no? It is very important to ask him the same, not feel only. Maybe the degree of feeling is different. So you are would like to emphasize upon, is this feeling in the sternum is like that you are feeling in the toe? Is it okay? It's good. Is it not okay? Also, you will go for another direction. Okay. If it is the same as above for cotton, okay. This means that there is no, there is an intact spinothalamic tract, but you need to check the dermatomes of the patient. Okay. Maybe this patient has a radiculopathy or a heterogeneous affection of his dermatome. You need to check the dermatomes from down to up. Okay, just checking the dermatomes between two sides by the cotton, comparing right side to left side from down to up. Okay. The same for the pinprick sensation. Yeah, we mentioned that the pain and temperature is carried by the spinothalamic tract. Okay, uh, spinothalamic tract. The one carried by the lateral spinothalamic tract, which is the pain and temperature. We are examine it by the brick, by the needle, and the light touch by the anterior spinothalamic tract. Okay, but we are dealing by both. We are dealing checking the spinothalamic tract. But to be يعني, meticulous, the lateral spinothalamic tract for pain and the temperature, which is manifested here by this pain. We are not checking the temperature in the exam. And the anterior spinothalamic tract, which is carrying the light touch of the cotton examined here. Okay, the dorsal column is responsible for vibration and proprioception. Okay, right. Let's continue. After you check the cotton in the sternum and go to check the cotton at the leg, you find it is the same intensity. Then you will go. If it's the same, okay, you will go up just to know the intact dermatomes all over the leg. We will give you a photo later regarding the dermatomes L1, L2, L3, L4, L5, then S1, S2, then the saddle area S3, 4, 5. Usually you will not go to the saddle area because it's a private area for the patient, but you are at least checking the L1, L2, L3, L4, L5, and S1. Okay, right. Bilateral. Examine it bilaterally to be sure that it's equal bilateral. This is regarding the cotton. After that, you will use the 10, okay. After that, you will go to the pinprick by using the needle. Start to at the sternum of the patient. Ask, do you feel here? Okay, close your eyes and go to the leg. Check the area of the big toe by the needle and ask him, do you feel here? Like same of the above, and check the other side also the same of the above. If it is the same, you are checking the dermatomes bilaterally from down to up to confirm that all the dermatomes is intact. Okay. This is if the sensation down is the same like at the sternum. Type. If the sensation down is not the same like the sternum, so you check the patient at the sternum regarding light touch or pinprick or even the vibration, and then you go down starting from the distal of the leg at the big toe area and ask the patient, do you feel here the cotton? Do you feel here the pinprick? Do you feel here the vibration? And the patient told you, no, I cannot feel anything. What will be the next step? This means you would like to know if there is any lesion, sensory affection. If this sensory affection is reaching to a specific level or no. Okay. I mean here we will go up by doing repetitive examination closely till from down from the big toe going to the knee, then to the hip, then even go above the trunk to check if there is any sensory level or no. Okay. The sensation impairment here can be divided into two categories. Okay, it can be either the sensory loss is reaching to the level below the knee, above the knee, or reaching to the hip. Okay, up to the hip, this is a category which is called the peripheral neuropathy. If the sensory loss reach to a level above the hip girdle or above the hip bundle, reaching to the trunk, you are going up, checking the pinprick or checking the light touch till reaching to the, say, the symphysis pubis or umbilicus or the sternum. This means that you have an affection of the spinal cord to a trunk level. There is a spinal cord affection. Okay, so any sensory affection which is still limited to the level below the hip joint, this is called peripheral neuropathy, peripheral nerve affection. If the sensory loss reach to the trunk level, it means above the area of the hip joint, And so you have here what's called a sensory level affection. So this means a spinal cord lesion. Okay, this is very important. Okay, usually if you go up, you need to check the level. If this level at the symphysis pubis, so it can indicate you a specific spinal segment affection. Okay, at the umbilicus, it is a level at T10. Okay, at the xiphisternum, it is at the level of T8. So it means that T8 segment of the spinal cord has a lesion, compression or spinal cord lesion. We'll mention that later. If the sensation was impaired from the big toe and you are going up till the level of the nipple, so this means that you have a T4 segment affection. So it means that fourth spinal cord segment is affected. Okay. For sure, after that, you need to check the back if there's any scar, any trauma, any tumor, any lesion like this. Okay. This is very important to know. And to check the level, ask the patient to close the eye while you are checking the sensation, and start from down to above. Okay, start from down the foot to above to reach to the level. Okay, and be sure if the sensation is normal, you will check the dermatomes to be sure that the dermatomes are intact on both sides. If the vibration if the impairment of the sensation, so you are going up to reach to the level. If the level reaching below the hip lesion, okay, this is peripheral neuropathy. If above, so it is a spinal cord lesion. Okay, for sure, when you are doing the vibration, okay, specifically for the vibration, because in vibration, you are checking the vibration. If the vibration is down and the big toe is intact, okay, and the patient said, yes, I can feel the vibration since here at the big toe, the same exactly like what I felt before in the sternum. No need to go up, okay? No need to go up, no need to go up, because already this means that you have an intact dorsal column affection, okay? But if you have the vibration is impaired at the big toe, you will go over the bony prominence from big toe to the medial malleus to the tibial tuberosity to the anterior superior iliac spine. Then from anterior superior iliac spine in the abdominal area, you will not find any bone to do. So you go directly to the costal margin and start rib by rib till reach to the clavicle or the mastoid process. Okay. As I told you, very important to make the patient closed eyes and check the dermatomes equal in both sides or no, or if there is a level, okay, this level usually you are speaking a level when you speak about the spinal cord. Okay, you are doing that there is loss of the sensory, all the sensation or loss of all modalities of the sensation till the level of say T10 of the umbilicus, for example. Okay, or if it is below that, it is called as stocking sensory loss. Stocking sensory loss, it is related to the peripheral neuropathy affection. But if the level, there is called a spinal cord level. Okay. Is it clear? If you have any question or suggestion, you can send to me.
Dr. Magraby, I have a question. Can I ask?
Yeah, for sure. Yes, for sure.
Okay. As you said, below, if it is below the inguinal ligament or the below the hip, it is always peripheral neuropathy. But sometimes we have like cauda equina syndrome, or sometimes we have like lower lumbar fractures in which we may have motor loss with sensory loss, like up till mid thigh.
Mm-hmm. Yeah, exactly. This is a very good question, Dr. Sabah. Thank you for this question. Let me illustrate for you. As you mentioned now, it is cauda equina. You know, cauda equina, it is not a lesion in the spinal cord because you know the spinal cord is finished at the level of L1, L2, the lower border of lumbar spine 1 and the upper border of lumbar spine 2. So at this level, the spinal cord will be finished. The cauda equina is the radicular nerves which go outside. This considered as peripheral nerve. It is not a central spinal cord affection. so that any lesion of this coda equina, you can deal it like a peripheral neuropathy. Okay, it will not affect the
I
spinal
mean to
cord itself.
say,
The spinal cord, if the lesion of the spinal cord itself, definitely for sure you will find a segment of the spinal cord affection, which will be started in the trunk from the cervical region till the symphysis pubis. You'll find a lesion of affection of spinal cord region.
okay, I got it. That means, just to clarify, if it is spinal cord, it has to be above L1, and you will find upper motor neuron signs, right? And as you said, cauda equina is a nerve, so that's why you have element signs along with sensory loss, right? Am I right?
Yeah. It will be, yes, it will be a filaments and lower motor neuron affection of coda equina, except if there is a lesion in the spinal cord itself and it take the ligaments. And I mean the spinal segment is intact. If the spinal segment is intact, so the lesions in the coda equina, this is considered lower motor neuron lesion. Except if there is a lesion in the spinal segment itself, this will lead to an upper motor neuron lesion. Okay.
Thank you, Dr. Magraby. I'm clear.
Welcome. Okay. I think the session will finish less than 1 minute. So another question. Okay, I will close this and send you another link, inshallah. Okay.
Doctor, can you send us the